Go ahead.
Good afternoon, everyone. I'm Dr. Craig Reich. I'm the Chief Medical Officer for Chinese Community Health Plan. And today we are going to review the Special Needs Plan Model of Care, or SNP MOC, as we call it. And so to 2024's Model of Care Training and Review. So what are the learning objectives? Number one is to gain an understanding and comprehension of CCHP's Special Need Plan. The second objective is to gain an understanding and comprehension of the elements of the SNP MOC. And at the end of the training, you'll be able to describe the best practices for the SNP MOC and describe how to improve coordination of care and improve member health outcomes. So provider training standards are issued by Code of Federal Regulations, Chapter 42, and mandates that special needs plans conduct training on the model of care for all employed and contracted providers annually. All CCHP participating providers who routinely take care of SNP members must receive training initially and annually thereafter. Initial training must be completed within 90 days of execution of contract and annually thereafter. Annual training is provided via live webinar, and attestation must be completed within 90 days from the live webinar. So what is the Special Needs Plan Model of Care? Special Needs Plans are Specialized Medicare Advantage Plans, or MA plans, for beneficiaries with specific circumstances. There are three SNP types. Chronic SNP, for members with severe or disabling chronic conditions. Institutional SNP, for members requiring institutional level of care. And dual eligible SNP members, or the D-SNP, are for members eligible for both Medicare and Medi-Cal or Medicaid. Model of care is a comprehensive plan for delivering integrative care management for the special needs member. CCHP's SNP is a D-SNP, which is the dual eligible SNP. The model of care is the architecture for promoting quality, integrating benefits, coordination of care, and operational processes. CCHP offers a dual SNP, as I mentioned. Enrollees must have both Medicare and Medi-Cal or Medicaid. It's offered only in the county of San Francisco. And enrollees are responsible for $0 of their covered medical services. D-SNP benefits. CCHP offers a wide range of special benefits for D-SNP members, which may include walk-in services at our member services areas, MTM or medication therapy management, disease management services, non-emergency transportation, holistic and complementary health services, community partnerships with CCHRC, over-the-counter allowance, flex benefit cards, and other benefits. Written documentation that describes the care management process and operations is required by Medicare and Medicaid, must be NCQA accredited, and renewal depends on scoring ranges from 1 to 3 years. CCHP received the 3-year approval in 2022, and there are 4 model of care domains and 15 elements. The 4 domains and the 15 elements are listed below. I'm not going to go through each of them, but they break down the functions, process, and procedures that each model of care must follow. Domain 1 is description of the SNP population. Domain 2 is the description of care coordination. Domain 3 is the provider network. Domain 4 is quality measurement and performance improvement. And so the SNP MOC responds to CCHP's mission of providing high quality, affordable health care in a culturally competent and linguistically appropriate manner. CCHP provides services to many different types of individuals, including the frail, elderly, high health risk individuals, low income and low socioeconomic population, individuals with multiple chronic and acute health problems, and et cetera, et cetera. What are the SNP MOC goals? Improve access to care, improve transitions of care, improve coordination of care, improve access to preventative health services, improve appropriate utilization of services, improve quality scores, improve member satisfaction with the provider and the plan, and improve health outcomes. So what does CCHP's SNP population look like? The demographics. Well, CCHP currently has 3,748 SNP beneficiaries in San Francisco. 96.6% of the population are Chinese. They age from 25 to 101 years. 64.9% are between 65 and 80 years. And 55.2% of beneficiaries are women. What is care coordination? Care coordination facilitates effective use of resources to reduce the overall cost of care with the overall goal of providing improved health outcomes. Care coordination provides a single point of contact for the member across the continuum of care. Coordination staff include registered nurses, social workers, the chief medical officer, clinical coordinators, and the staff. They work collaboratively with the member, family, significant other, guardian, providers of health care to implement a plan of care which meets the individual's needs. And so what are some care coordination activities? The care coordinators will perform an assessment to identify individual health needs. They will develop a comprehensive individualized care plan or ICP. They will identify barriers to goals and strategies to address, provide personalized education for optimal wellness, engage preventative care, post-discharge planning, reviews and educates on medication regimen and management, assists the member to access community resources, and assist the caregiver when member is unable to participate. What is a health risk assessment? An HRA is conducted for each member enrolled in the SNP. CCHP administers an HRA to each member. It's a self-reported survey which includes questions on medical, psychosocial, cognitive, functional, and mental health. Consistent with CMS HRA regulation, the HRA was updated in 2024 to include questions regarding housing stability, food security, and access to transportation. Initial HRA is sent upon effective enrollment, and then annually, within 365 days of the last HRA. Telephonic outreach is conducted if no HRA is returned within 1 month of the mailing date. HRA provides the basis for the development of the plan of care, and care coordinators will review the HRA and may contact the member for follow-up. This is what an HRA looks like. Face-to-face encounter. This is a new addition to the care coordination plan as instituted by CMS. CMS requires that all SNPs must provide for face-to-face encounters for the delivery of healthcare, care management or care coordination services as feasible on at least an annual basis. The care coordination team may engage with the member in person where possible and feasible, and or collaborate with a provider for the in-person contact, such as contracted home health, case manager, facility or office provider, community health worker, etc. May work with various providers or entities to coordinate the member's need. When in-person engagement is not available or appropriate, such as when the member refuses, CCHP may utilize alternative communication methods such as telemedicine platforms, telephonic outreach, or mail. Development of the ICP or Individualized Care Plan. CMS regulation requires an individualized care plan is developed for each member enrolled in the SNP. HRA responses are used to develop or update the ICP. Data such as claims and labs is used to develop the member's ICP when no HRA response is received. The ICP is maintained and stored to assure access by all care providers and meet HIPAA and professional standards. ICP may include the following: members' healthcare preferences, goals and objectives and targets, interventions and services tailored to the member's unique and individual needs, documentation if time-bound goals met or not met, and it utilizes evidence-based guidelines such as interqual care guidelines. So the ICP or Individualized Care Plan goals, the model is a SMART model: specific, measurable, attainable, relevant, and time-bound. All goals must meet those requirements. An ICP developed addresses HRA responses and member preventative care gaps. Members that do not respond to the HRA will receive an ICP based in part on claims or encounter data. ICP is documented in the care management tool and updated when a member's health status changes, or at least annually. ICP updates and changes are communicated to the member, caregiver, and provider. This is an example of an ICP, and this is sent to the member and the provider. ICPs are communicated via fax and mail and secure email. Providers are asked to sign and return the physician care plan statement to care coordination department. Interdisciplinary care team, or ICT, and staffing. Participants of the ICT may include, but not limited to, member and designated representative, primary care provider, chief medical officer, care coordination manager, care coordination nurses, medical social workers, MTM pharmacists. The ICT composition is determined by each member's needs. Provider and member participation in the ICT can better help address the member's needs and achieve the plan of care. The ICT may provide input and evaluate members' plan of care. The CCHP holds ICT meetings regularly with clinical staff. Transition of care. Care transitions occur when a member moves from one healthcare provider or setting to another. For example, a member was admitted to hospital and discharged to home, acute rehab, or skilled nursing facility. The member's plan of care is updated in the event of a health status change or care transition. Primary care providers are notified when their patient has a transition of care. Our clinical staff will assist members to ensure appropriate follow-up care is arranged after a transition of care. Network providers. The network must incorporate relevant clinical information in the member's plan of care. Follow transition of care protocols. Utilize evidence-based care guidelines. Annually review delegated group utilization decisions and member appeals process. Review patient medication profiles in the MTM program. Contribute to improve the STAR and HEDIS outcome reporting. Help improve member experience through CAPS and HOS data collection. And may participate in the Quality Improvement Committee quarterly. The role of the provider. The provider plays an integral part of the care team. Must encourage the member to work with CCHP's care coordination team. Take calls from the member's care coordinator. Collaborate with the member's care coordinator to address needs. Review the member's plan of care and send back the care plan attestation. Participate in the ICT and complete the annual MOC training. MOC measurement. How do we measure the effectiveness of the MOC? CCHP measures the effectiveness of the MOC by utilizing standard measures to monitor performance such as HEDIS data, utilization metrics, member experience metrics, and member satisfaction with care coordination. In summary, CCHP SNP MOC needs to be your model on managing care for your SNP patients. The model supports the mission of CCHP and its business objectives. You are key to improving our members' health outcomes. Please complete the training attestation, which can be obtained with the QR code. These are contacts for you as necessary, the Care Coordination Department and Provider Relations. Some references, and I thank you for attending today's training. Goodbye.